This episode is based on the literature review Cervicogenic Dizziness, Diagnosis and Management, Cervical-Vestibular Interaction, and Combined Therapy, published by Australian Dizziness Clinics, available at australiandizzinessclinics.com.
Welcome back to our Clinical Explainer series. Today, we're zeroing in on the exact dose, the progression, and the outcome targets that drive an 8 to 12-week response in cases of cervicogenic dizziness. If you've been following along with us, you know that managing this condition is rarely straightforward, but having a precise, evidence-based roadmap, well, that completely changes the game.
So let's just dive right in and address the clinical elephant in the room. Why does a combined approach consistently beat manual therapy alone? We've all had those stubborn cases, right? You clear the cervical joints, the neck feels fantastic, but the patient is sitting there still complaining of that floaty, unsteady sensation. Why does a single modality approach fall short here? The truth is, a true, isolated cervicogenic dizziness case is actually quite rare. Most of these cases are carrying a vestibular or migraine co-driver. To get real, lasting results, we absolutely need a combined dose that treats both inputs.
Here is our clinical roadmap for the next 10 minutes. 1. Why combined therapy wins. 2. Manual therapy and proprioception. 3. Adding vestibular exercises. 4. Outcome targets and timelines. And 5. Troubleshooting sluggish responses.
Okay, starting with Section 1, Why Combined Therapy Wins by Treating Dual Inputs.
When we're dealing with cervicogenic dizziness, especially post-trauma situations like whiplash, we are almost always dealing with overlapping, compromised systems. It's like a giant puzzle. Cervical, vestibular, and visual inputs all converge to create our overall sense of head-on-trunk position. Now, disordered cervical input, whether that's from joint dysfunction or muscle injury in those deep upper cervical muscles, generates a sensory mismatch. The brain essentially gets confused and interprets this as motion or instability. On its own, this mismatch might be small, but it becomes cumulative and highly symptomatic when you combine it with reduced vestibular function or high visual demand. So treating just the cervical circle simply won't stabilize the whole system if the vestibular circle is also disrupted.
Moving on to Section 2, Manual Therapy and Proprioception, which is our first pillar of treatment.
Getting the dosage right here is absolutely crucial. We need to be highly specific. Step 1 is cervical mobilization. The current evidence points us to a typical dose of 2 to 3 manual sessions a week, running for about 3 to 4 weeks. The main goal? Restoring that segmental motion. But listen, manual therapy alone just isn't enough. It has to be strictly paired with Step 2, active daily home drills, done 1 to 2 times a day. It's a two-part harmony. The mechanism of our success here is partly mechanical from the actual mobilization, but it relies heavily on the proprioceptive retuning generated by those active drills.
And what are those drills? They're the absolute cornerstone for long-term recovery. We're talking about targeted joint position error, or JPE, retraining drills. We use eye-head coordination tasks, and we slowly introduce a graded postural challenge progression. On top of that, ergonomic correction is vital, especially for our office workers who are dealing with chronic, daily strain. Taking the time to really educate your patient on these postural levers builds massive confidence. When you properly frame the diagnosis and explain the why behind the exercises, it dramatically reduces the frustration patients feel when they're battling invisible symptoms like chronic unsteadiness.
Let's hit Section 3, adding vestibular exercises to complete the package.
To elevate your patient outcomes from just okay to excellent, vestibular exercises must be integrated. Layering in gaze stabilization, balance work, and graded exposure to provocative motion is totally non-negotiable for patients showing any concomitant vestibular signs or post-traumatic features. Keep in mind, whiplash is the most common precipitant here, and a huge chunk of whiplash patients also have a peripheral vestibular insult from the exact same mechanism of injury. You literally cannot afford to just treat the neck.
I want to pause here for a second to really emphasize this quote. Combination therapy outperforms manual therapy alone in published cervicogenic dizziness trials. This isn't just clinical intuition or a hunch, it is the evidence-based reality. Integrating vestibular care alongside your manual therapy is definitively the superior clinical pathway for these patients, for sure.
All right, Section 4, Outcome Targets and Timelines. Essentially, this is our clinical scorecard.
We need concrete benchmarks to track against during that critical 8 to 12-week recovery window. Our very first target? The Neck Disability Index, or NDI. By the end of our treatment window, we expect to see an NDI drop of more than 5 points. That signifies a really meaningful, functional improvement in how the patient's neck is tolerating their daily life.
Next up on the scorecard is the Visual Analog Scale, or VAS, specifically tracking their dizziness. We are aiming for a drop of 2 or more points. Remember, these folks are usually describing an unsteadiness or floating feeling, not a true spinning vertigo. So, tracking the intensity of that specific spatial disorientation is key.
Moving to our third objective metric, we look back to the physical exam. When you retest the joint position error at the wall, using the laser pointer mounted on the headband, the error should now measure under 5 degrees. Hitting this number proves that our proprioceptive retraining drills have actually done their job and recalibrated the sensory motor system.
And finally, to round out our functional scorecard, we want to see an improvement of 4 or more points on the Functional Gait Assessment, or FGA. If you are hitting these numbers at the 8 to 12-week mark, your combined intervention has been a massive clinical success.
Finally, Section 5, troubleshooting sluggish responses. Because, let's be real, what happens when things just don't go according to plan? Every good clinician needs a solid fail-safe for when a patient misses that expected recovery trajectory. Here's how you map out the clinical timeline to protect both yourself and your patient. Week 12 is your target recovery window. But, and this is important, you do not wait until week 12 to pivot. Week 4 is your early check. If a patient is showing a sluggish response by week 4, meaning their symptoms are totally stagnant despite complying with the manual and active therapy, you must implement an early rescreen. By week 8, you are doing a formal reassessment of both cervical and vestibular contributions. So why is this specific timeline so critical? Because those dominant drivers can completely change. As the early cervical symptoms start to clear up, an underlying issue might suddenly become unmasked. For your non-responders, your sluggish response pathways require you to rescreen. You need to weigh the possibility of a vestibular hypofunction, maybe utilizing a video head impulse test, or VHIT, against the possibility of a vestibular migraine. More often than not, a case that initially looked purely cervicogenic is actually being held back by an untreated vestibular or migraine driver that has shifted right to the forefront. Rescreening is your ultimate failsafe.
Before we wrap up, ask yourself, how many of your stubborn neck pain patients are actually struggling with an undiagnosed vestibular mismatch? In video 4, we close the series with outcome tracking, the 8-week rescreen, and the onward referral pathways for non-responders. For additional resources, including the full literature review, the clinical cheat sheet, audio overviews, and the rest of this video series, visit AustralianDizzinessClinics.com. Please subscribe to the channel and leave a rating to support the series.